there is this pervasive, almost comforting illusion we maintain about our own biology. We tend to view the human body as this perfectly engineered, perfectly synchronized orchestra, like the lungs draw in oxygen, the heart faithfully pumps it around the systemic circuit, the kidneys just quietly filter the exhaust. It feels orderly.
Yeah, it feels predictably safe.
Yeah.
Right up until it isn't.
Exactly, because the moment you look past that superficial layer and peer into the visceral engine room, specifically the hepatic biliary system, housed right there in the abdomen, that illusion of peaceful homeostasis it completely shatters.
It shatters because you realize that our internal physiology is constantly teetering on the edge of catastrophic failure. I mean, the margins for error are terrifyingly thin. We are maintaining our existence through this hyper-complex, deeply fragile web of chemical reactions and pressure gradients that are always just one minor disruption away from chaos.
And that is exactly our mission for this deep dive. We are taking a comprehensive collection of clinical sources, research notes, and heavily detailed hepatic nursing protocols, and we're going to deconstruct this intricate, fiercely interconnected world of the liver, the gallbladder, and the pancreas.
Which is a massive undertaking, but so necessary.
Oh, massively necessary. But we are not here to just memorize anatomical vocabulary for you or recite a textbook table of contents. The goal today is to examine the specific cellular mechanics and the fluid dynamics of this system, to understand exactly why one falling domino like, a rogue virus or a blocked duct or failing tissue triggers a systemic cascade that can literally take down the brain, the kidneys, and the entire circulatory system.
Right. And to do that, we have to stop looking at these organs in isolation. The hepatic biliary system is, well, it's the central metabolic hub of the body. It dictates the osmotic pressure of your vascular system, the coagulation of your blood, the neurochemical environment of your brain. So when this hub experiences a structural or functional failure, the shockwave isn't localized. It violently disrupts the entire human network.
Okay, let's unpack this, starting with the liver itself, because I think the liver often gets sidelined in favor of the heart or the brain when we talk about vital organs, which is just a massive disservice.
It's wildly underappreciated.
It is. It's the hardest working, most underappreciated multitasker we have. If you look at the raw physiological output, the liver is managing an absurd number of simultaneous processes. I mean, it's the water treatment plant, the power grid, and the manufacturing hub all rolled into one. Our clinical sources utilize the baptism mnemonic to categorize these core functions for you.
Right, baptism, bile production, albumin synthesis, protein metabolism, toxin detoxification, immune function, storage like vitamins and glycogen, and metabolism of carbs and fats.
Exactly, and looking closely at the mechanisms behind them reveals just how much load this organ carries. Let's look at the A in that mnemonic albumin synthesis. We know it's a protein, but its role in maintaining vascular integrity is, well, it's foundational.
Yeah, what's fascinating here is that albumin is arguably the most critical protein in your entire bloodstream. It makes up about half of the total protein found in blood plasma, and its primary job is maintaining oncotic pressure.
Okay, oncotic pressure. Break that down for us.
So to visualize this, consider the capillary beds where your blood interacts with your tissues. The hydrostatic pressure from the heart's pumping action is constantly trying to physically force water out of the blood vessels and into the surrounding tissue spaces. It's a mechanical push.
Like a leaky hose under high pressure.
Exactly like that. But albumin is this massive, negatively charged molecule that stays inside the vessel. And because of its osmotic pull, it acts like a chemical magnet. It draws that water back into the vascular space, constantly fighting that outward hydrostatic push and keeping your blood volume stable.
So, if the liver's synthetic function fails, your albumin production just plummets. You lose that chemical magnet, the hydrostatic pressure goes unchecked, and fluid simply seeps out of the vascular system and pools in the interstitial spaces.
Right.
Which is why we see profound peripheral edema, right?
Yeah.
Like swollen legs and ascites. That massive fluid buildup in the belly-end liver failure. The water is literally escaping the plumbing.
It is escaping the plumbing, and the cascade doesn't stop there. Because that fluid is leaving the vascular space, your total circulating blood volume drops. The body suddenly thinks it's bleeding to death, even though the fluid is just displaced inside you.
Oh, wow, so it panics.
Complete panic. This hypovolemia triggers an entirely separate stress response in the cardiovascular and renal systems, which we will definitely get into.
We have to. But first, let's look at the T in that baptism functional breakdown toxin detoxification. The liver receives nutrient-rich, but also toxin-heavy blood directly from the digestive tract via the portal vein. It has to neutralize everything: pharmacological agents, natural metabolic waste, everything. And the most pressing natural waste product the liver deals with is ammonia, right? Which comes from protein metabolism.
Exactly. The breakdown of amino acids inevitably strips off the nitrogen-containing amidamine group, which forms ammonia. And ammonia is a highly neurotoxic compound. The liver's job is to rapidly capture that ammonia and run it through the urea cycle, basically converting it into water-soluble, relatively harmless urea that your kidneys can just easily pee out.
Which means when the hepatocytes, the main functioning cells of the liver, when they die or lose their capacity, that urea cycle stalls out.
Right, the factory shuts down.
The ammonia bypasses the liver entirely and enters the systemic circulation. And it crosses the blood-brain barrier with alarming ease. And this isn't just a matter of, the brain getting cloudy. The ammonia actively alters the neurochemical environment.
It's actively destructive. It gets taken up by astrocytes in the brain, which try to buffer it by synthesizing glutamine. But glutamine is highly osmotically active.
Which means it pulls water, right?
Yes. It pulls water straight into the astrocytes, causing them to physically swell. This leads to cerebral edema, altered neurotransmission, and the devastating clinical presentation of hepatic encephalopathy.
What's wild to me is how these entirely disparate functions, making albumin, clearing ammonia, producing bile, storing glycogen, synthesizing coagulation factors, all happen within the same parenchymal tissue.
Yeah, the hepatocytes are doing it all. So when the liver is under assault, the failure is rarely isolated to just one function. The entire infrastructure begins to crumble simultaneously.
Which brings us to how clinicians actually monitor this unraveling infrastructure for you. Liver function tests, or LFTs. The source material goes really deep into this. When you look at a hepatic lab panel, you're essentially looking at the biochemical distress signals of the liver. But interpreting this alphabet soup of AST, ALT, ALP, and GGT, it requires understanding where these enzymes actually live on a cellular level. So can you translate this for us? Let's start with the transaminases, AST and ALT.
Sure. So AST and ALT are intracellular enzymes. Under normal, healthy homeostatic conditions, they belong inside the hepatocyte, doing their job facilitating amino acid metabolism. They should only be present in the bloodstream in very low baseline concentrations, just from normal cell turnover.
Like regular maintenance shedding.
Exactly. But when a lab panel shows significantly elevated AST and ALT, it indicates hepatocellular injury. The cell membrane of the hepatocyte has been compromised or destroyed, and it's literally spilling its internal contents directly into your systemic circulation.
But the clinical literature makes a very sharp distinction between the two. ALT is considered far more specific to the liver, whereas AST is found in myocardial tissue, like the heart and skeletal muscle and the kidneys.
Right, so a spike in AST without a corresponding spike in ALT might just mean the patient recently ran a marathon and broke down some muscle, or maybe they had a myocardial infarction, a heart attack.
But ALT points the finger firmly at the liver.
Firmly at the liver. That specificity is a crucial diagnostic anchor. However, the ratio between the two provides an even deeper cellular narrative. In most forms of acute liver injury, like, say, viral hepatitis, ALT will be higher than AST.
Okay.
But when you look at the pathology of alcoholic liver disease, that ratio flips completely upside down.
Yeah, our sources highlight that specific phenomenon, and it's a massive clinical pearl. An AST to ALT ratio greater than 2-to-1 is a huge hallmark for alcoholic cirrhosis. And the mechanism behind why that happens is what I find so compelling. Alcohol doesn't just broadly damage the cell. It specifically assaults the mitochondria.
And this is where understanding the subcellular distribution of these enzymes is vital. ALT is found almost exclusively in the cytoplasm of the hepatocyte, the jelly-like substance filling the cell.
Right.
AST, however, has two distinct isoenzymes. There's one in the cytoplasm, but there is a massive, significant reserve located deep inside the mitochondria. Now, ethanol metabolism generates reactive oxygen species, free radicals. These inflict severe oxidative stress, and they preferentially destroy mitochondrial DNA and mitochondrial membranes.
So when the alcohol literally shreds the mitochondria, it releases that massive reserve of mitochondrial AST into the blood, driving that number way up.
Exactly. And to add another layer to that, chronic alcohol abuse typically results in a deficiency of vitamin B6 pyridoxal phosphate.
Which you need to make the enzymes, right?
Yes, it's a required cofactor for synthesizing both of them. But ALT synthesis is far more dependent on vitamin B6 than AST is. So the alcohol is simultaneously destroying the AST-rich mitochondria, causing that spike, while actively starving the cell of the raw materials it needs to replace the ALT.
That is incredible. So the 2-to-1 ratio isn't just an arbitrary diagnostic number. It is the literal biochemical footprint of mitochondrial destruction and nutritional depletion.
It's the exact story of the damage written in the blood. Now, moving beyond the transaminases, we have to look at the other side of the LFT panel, ALP, or alkaline phosphatase, and GGT, gamma-glutamyl transferase. If AST and ALT signify cellular membrane rupture, ALP and GGT signify a mechanical pressure problem within the biliary plumbing.
Right, because ALP is highly concentrated in the cells lining the bile ducts, not deep inside the hepatocytes themselves.
Precisely.
So if there's a physical obstruction, say a gallstone lodged in the common bile duct or a tumor compressing the biliary tree, the bile physically backs up. The hydrostatic pressure inside those tiny ducts skyrockets. That localized pressure plus the detergent effect of the stagnant bile acids irritates the ductal cells, causing them to ramp up synthesis and release of ALP.
And because ALP can also originate from bone tissue, for instance, during periods of rapid bone growth in kids or in conditions like Paget's disease, GGT serves as the necessary confirmation.
Oh, because GGT is specific to the biliary tract.
Right. GGT is highly sensitive to biliary tract disease. If ALP is elevated but GGT is normal, you look at the bones. If both ALP and GGT are elevated, you have definitively localized the pathology to a cholestatic issue. You have a bottleneck in the liver's drainage system.
The diagnostics become even more elegant when we factor in bilirubin. The clinical distinction in the sources between indirect or unconjugated bilirubin versus direct conjugated bilirubin allows you to pinpoint exactly where the physiological assembly line is broken down.
It really does. Bilirubin is the waste product of heme metabolism, so your spleen constantly destroys old senescent red blood cells, releasing this raw, unconjugated bilirubin into the blood.
But it's highly lipid soluble, right? Meaning it can't be excreted in urine or bile in that raw state. It repels water.
Exactly. It requires the liver to perform a critical chemical transformation. Unconjugated bilirubin binds to albumin in the blood, which acts like a shuttle bus carrying it to the liver. Inside the hepatocyte, an enzyme called UGT attaches a glucuronic acid molecule to the bilirubin.
That's conjugation.
Yes, that conjugation process suddenly makes the bilirubin water-soluble. It is now direct bilirubin, ready to be safely secreted into the biliary network, dumped into the intestines, and eliminated from the body.
So if a patient's lab work shows a massive spike in unconjugated indirect bilirubin, the breakdown is happening upstream of the liver's processing plant.
Right before it even gets conjugated.
Usually that points to hemolysis.
Yeah.
The red blood cells are rupturing at an accelerated rate, maybe due to an autoimmune disorder or a mismatched blood transfusion. The liver simply cannot conjugate the raw material fast enough. The warehouse is completely overwhelmed by the delivery trucks.
Conversely, if the lab shows high conjugated direct bilirubin, the liver has actually successfully done its job. It attached the glucuronic acid. The problem lies downstream.
The plumbing is blocked.
Exactly. The conjugated bilirubin was prepped for excretion, but a physical obstruction in the biliary tract forced it to regurgitate back into the hepatic sinusoids and leak into the systemic bloodstream. So analyzing this fractionated bilirubin is essentially mapping the exact coordinates of the system failure.
Now, despite all these highly specific biochemical markers, the gold standard for officially diagnosing severe structural changes like cirrhosis remains the physical liver biopsy. You literally have to put a needle in and look at the architecture of the tissue under a microscope. And here's an observation from the nursing text that I wanted to push back on, or at least highlight, because it's surprising. The protocol contains a very specific, absolute post-procedure intervention. The patient must be positioned flat on their right side for exactly 2 hours immediately following the biopsy. Why?
It seems oddly specific, right? But the rationale behind this intervention illustrates the severity of end-stage hepatic disease. We have to consider the hemodynamics of the organ. The liver is essentially a massive, highly vascular sponge.
Yeah, it receives dual blood supply from both the hepatic artery and the portal vein. Doesn't it hold roughly 15% of your entire body's blood volume at any given moment?
It does. And you are taking a core sample out of that highly pressurized, blood-filled sponge with a needle. But the real danger lies in the failure of the liver's synthetic function we discussed earlier. The liver manufactures nearly all the coagulation factors required for your blood to clot, specifically factors 2, 7, 9, and X.
So a patient requiring a biopsy for cirrhosis almost certainly has a compromised coagulation cascade.
Exactly. Their blood simply will not clot efficiently. This creates a highly precarious clinical scenario. You have created an open puncture wound in a highly vascular organ, in a patient who lacks the physiological tools to form a stable fibrin clot. The risk of massive, exsanguinating internal hemorrhage into the peritoneal cavity is immense.
Which is where the right-sided positioning comes in. It's pure, simple physical mechanics. The liver is situated in the right upper quadrant of the abdomen. By placing the patient flat on their right side, you are trapping the liver between the rib cage and the mattress.
You're using the mass of the patient's own body to apply continuous, unyielding mechanical pressure directly against the puncture site.
You are acting as an external tourniquet for an internal organ. That is brilliant.
It's a stark reminder that when the biochemical pathways fail, clinicians have to rely on basic physics to keep the patient alive. And this transition from chemical failure to structural failure is the defining characteristic of cirrhosis.
Let's transition into that structural collapse, because cirrhosis isn't just a loss of functioning cells. It is a fundamental architectural ruin of the organ. When hepatocytes are chronically injured, whether by alcohol, viral infiltration, or even fat accumulation, they release inflammatory cytokines.
Right, distress signals.
And these cytokines activate a specific type of cell living in the liver called the hepatic stellate cell. Now, normally stellate cells just quietly store vitamin A. They chill out. But once activated by chronic inflammation, they morph into myofibroblasts and start violently churning out dense collagen.
This fibrogenesis is the core pathology of cirrhosis. The liver tissue is normally arranged in these beautiful, highly permeable sinusoids that allow blood to wash directly over the hepatocytes for maximum filtration. But as the stellate cells lay down massive amounts of scar tissue, those delicate sinusoids are obliterated. The tissue becomes nodular, stiff, and highly resistant to blood flow.
To understand the hemodynamic nightmare this creates, we have to look at the portal vein. I like to use the concert stampede analogy for this. The portal vein is not a normal blood vessel. It is a high-volume convergence point. All the venous outflow from the stomach, your entire small and large intestines, the spleen and the pancreas, it all merges into this single major vessel, trying to get through the doors of the liver for processing before returning to the heart.
And imagine a high-pressure hydraulic system designed to push massive volumes of fluid through a highly porous, low-resistance filter. But cirrhosis replaces that porous filter with a wall of dense concrete. The doors are locked. The blood from the entire gastrointestinal tract continues to surge forward, driven by arterial pressure, but it suddenly hits the fibrotic resistance of the scarred liver.
The blood cannot get through. It backs up, creating a massive spike in hydrostatic pressure within the portal venous system, portal hypertension. This isn't a localized problem. The pressure wave propagates backward through the entire splanchnic circulation.
It's a terrifying cascade. The body desperately tries to decompress the system by forcing the blood into smaller collateral venous networks that bypass the liver entirely. This diversion of blood flow is a catastrophic compensatory mechanism. The pressure forces massive volumes of blood upward through the left gastric vein, driving it into the submucosal veins of the lower esophagus.
And those veins were never meant to handle that kind of flow, right?
Yeah. Never. They were never evolutionarily designed to handle high-pressure, high-volume flow. As the portal blood forcibly engorges them, they dilate into large, tortuous, thin-walled varices protruding directly into the lumen of the esophagus.
Esophageal varices,
Right.
which makes them incredibly vulnerable. The submucosa of the esophagus is thin, and the patient is swallowing abrasive food. If one of these highly pressurized, engorged varices in the throat ruptures, it is an absolute medical emergency. The patient will experience massive hematemesis, vomiting bright red blood, and because they lack hepatic coagulation factors, they can exsanguinate in minutes.
It's one of the most feared complications in hepatology.
Which is why the text has that critical safety warning. You never blindly place a nasogastric tube, an NG tube, in these patients. The sheer mechanical friction of the plastic tube sliding down the esophagus can easily shear open a fragile varix.
Exactly. You could induce a fatal hemorrhage just by placing a tube. But the systemic ramifications of this portal hypertension go even further. It leads to one of the most complex physiological miscommunications in human biology, hepatorenal syndrome.
Here's where it gets really interesting for me. The text mentions hepatorenal syndrome, where the kidneys fail. But if the liver is the problem, why on earth are the kidneys shutting down?
It's brilliant, albeit tragic, physiology. In hepatorenal syndrome, a patient with advanced cirrhosis experiences rapid, profound renal failure, despite their kidneys being histologically normal. There is no intrinsic disease in the nephrons. The kidneys are structurally fine.
So why do they stop filtering blood?
The answer lies in how the systemic vasculature responds to the portal hypertension we just talked about. As the pressure in the portal system skyrockets, the endothelial cells lining the blood vessels in the splanchnic bed, the entire digestive tract start releasing massive amounts of nitric oxide, which is a potent vasodilator.
Ah, so they widen to relieve the pressure.
Yes. The splanchnic vessels dilate to an extreme degree in an attempt to accommodate the backed-up portal blood flow. This causes a massive volume of your body's circulating blood to pool entirely within the abdominal cavity.
And this is where the miscommunication happens, right? Because so much blood is sequestered in those dilated splanchnic vessels in the belly, the effective arterial blood volume, the actual volume of blood returning to the heart and being pumped to the rest of the body, just plummets. Your systemic blood pressure drops.
Exactly. And the kidneys are exquisitely sensitive to changes in systemic perfusion pressure. They are equipped with baroreceptors in the juxtaglomerular apparatus. When the kidneys sense this severe drop in effective arterial blood volume, they interpret it as systemic hemorrhage or profound dehydration. They don't know the blood is hiding in the abdomen, they just know they aren't receiving enough pressure.
So the kidneys panic. They mount a massive, desperate defense to save the body's blood pressure. They activate the RAAS pathway, the renin-angiotensin-aldosterone system, and stimulate the sympathetic nervous system. This causes intense systemic vasoconstriction. The kidneys literally clamp down their own blood vessels, the afferent arterioles feeding the filtration units, trying to increase the pressure and conserve sodium and water.
But they clamp down so aggressively and persistently that they drastically reduce their own cortical blood flow. They literally starve themselves of oxygen and perfusion in a misguided attempt to rescue a collapsing circulatory system. The glomerular filtration rate crashes to near zero. The kidneys basically commit physiological suicide.
Wow. And the ultimate proof of this mechanical miscommunication is what happens during a liver transplant. If you take a patient with end-stage hepatorenal syndrome who requires dialysis, and you surgically replace their cirrhotic liver with a healthy donor liver.
The portal hypertension instantly resolves.
Exactly. The splanchnic vessels constrict back to normal, the effective arterial blood volume normalizes, and those completely failed kidneys will just wake up and instantly start producing urine again within hours. The kidneys were perfectly fine. They were just reacting logically to a fatally broken hemodynamic environment.
It is a stunning example of how a localized structural failure in the liver dictates the fate of remote organ systems. And we see a similarly devastating secondary effect when we look back at hepatic encephalopathy and how clinicians manage that neurotoxic ammonia buildup in the brain we discussed earlier.
Yeah, let's talk about the symptoms of that ammonia buildup because they are haunting. You see severe confusion, lethargy, fetor hepaticus, which is this musty, sweet breath odor, and asterisk.
The flapping hand tremor.
Right, the flapping tremor of the hands, caused by the ammonia actively disrupting the motor pathways. Treating that requires an incredibly clever pharmacological manipulation of the gut microbiome. The primary intervention is lactulose.
Right. Lactulose is a synthetic, non-absorbable disaccharide. It's a laxative. It passes through the stomach and small intestine entirely intact until it reaches the colon. There, the colonic bacteria metabolize it into lactic acid and acetic acid. This fundamental change in the chemical environment lowers the pH of the colon, making it highly acidic.
And this is where the physics of ion trapping comes into play, which is super cool. The ammonia NH3 that is circulating in the bloodstream is highly diffusible. It easily crosses the intestinal mucosa into the colon. But once the NH3 enters that newly acidic environment created by the lactulose, it picks up a hydrogen ion.
And it gets converted into ammonium NH4 plus.
Exactly. Ammonium is a positively charged ion. It cannot cross the lipid membrane of the intestinal wall to get back into the bloodstream. It is chemically trapped inside the lumen of the colon. Furthermore, lactulose acts as a profound osmotic laxative, drawing water into the bowel to forcefully expel the trapped ammonium in the stool.
You are systematically acidifying the gut to pull a neurotoxin out of the brain and flush it away in the toilet.
It's wild. Our sources also pair this with rifaximin, a broad-spectrum antibiotic that is localized, meaning it's poorly absorbed and stays in the gut. Rifaximin actively destroys the urease-producing bacteria in the gut that manufacture the ammonia in the first place.
So you use the antibiotic to shut down the ammonia factories, and you use the lactulose to trap and eliminate whatever is already in circulation. It's a two-pronged attack. And this manipulation of the gut is also intimately tied to how we manage the massive fluid shifts of cirrhosis.
Right, via sites.
Yes. We discussed the loss of oncotic pressure and the hydrostatic portal hypertension leading to ascites, the accumulation of liters of serous fluid within the peritoneal cavity. It can make a patient look like they are full-term pregnant. When this accumulation becomes so massive that it physically restricts the diaphragm, compromising their breathing, a paracentesis is required.
Right, where the clinician physically inserts a large bore needle through the abdominal wall to drain the fluid.
The nursing protocols emphasize this crucial, absolute pre-procedure checklist item. The patient must completely empty their bladder, they have to void, before the needle is ever introduced. It is entirely an issue of anatomical displacement. When your bladder is full, it ceases to be a pelvic organ. It distends upward, rising above the pubic bone and expanding directly into the lower abdominal cavity. In a patient with massive ascites, the anatomical landmarks are already severely distorted by the fluid.
So if you go in blind with a needle,
If the clinician inserts the paracentesis trocar into the lower abdomen while the bladder is distended, the risk of popping the bladder wall is exceptionally high. That would introduce urine directly into the peritoneal cavity and guarantee severe peritonitis. Voiding shrinks the bladder back down behind the pelvic bone, safely out of the trajectory of the needle.
such a simple thing but saves lives. Once that ascitic fluid is drained, it provides a crucial diagnostic window via the SAG score, the serum ascites albumin gradient. I love the math here. You measure the albumin concentration in the patient's blood serum, and you subtract the albumin concentration found in the aspirated belly fluid.
And the resulting gradient is highly specific. If the SAG score is 1.1 or higher, it indicates a high gradient ascites. This means the fluid was driven out of the vessels purely by the overwhelming hydrostatic pressure of portal hypertension. The immense pressure forces the water through the capillary walls, but the large albumin molecules are left behind in the blood. Therefore, the blood has high albumin, the fluid has very low albumin, and the difference, the gradient, is 1.1 or higher.
But if the SAG is lower than 1.1, the gradient is low. This indicates that portal hypertension is not the culprit. Instead, the blood vessel permeability itself is broken, allowing both water and the large albumin molecules to leak out at the same time. This usually points to something else, like peritoneal carcinomatosis cancer or tuberculosis of the abdomen. The SAG instantly differentiates a mechanical liver pressure problem from a malignant cancer process.
It's a vital tool. However, even if the SAG confirms it's just portal hypertension, that acidic fluid remains a massive hidden danger. The splenic congestion caused by the portal hypertension severely compromises the mucosal barrier of the intestines. The gut wall becomes edematous and highly permeable, allowing normal enteric bacteria like E. coli to translocate across the intestinal wall and directly seed the acidic fluid.
Wow, causing SBP, spontaneous bacterial peritonitis. The belly fluid basically acts as a massive, warm, nutrient-rich culture medium. And SBP is notoriously insidious, right? It's a silent, deadly infection. The patient might not have a rigid, painful abdomen. They might just have a low-grade fever or suddenly get more confused. If it's not urgently diagnosed and treated with antibiotics and albumin replacement, it's deadly.
The mortality rate is staggering. This systemic fragility really forces us to examine the root causes of the initial hepatic inflammation. While alcohol and metabolic dysfunction are massive drivers of cirrhosis, the viral hepatitides represent a profoundly complex mechanism of cellular sabotage. We have to decode these viral saboteurs.
Yes, let's transition into the ABCs of liver inflammation. What causes this damage before it ever becomes cirrhosis? I really want to use the mnemonics from the text to make the viruses memorable for you. Let's start with the enterically transmitted ones, hepatitis A and E.
Okay, the acute ones.
Right. Hep A, I use the mnemonic A for ass because it's fecal-oral transmission. It's acute only. It never becomes chronic. And there's a highly effective vaccine for it.
Right, it enters via contaminated food or water. What's crucial here is that the Hep A virus itself doesn't actually kill the hepatocyte. The clinical illness, the jaundice, the fever, is the result of the host's own cytotoxic T cells recognizing the infected liver cells and actively destroying them to clear the virus. Once cleared, the liver regenerates.
Then we have Hep EE for eat or water, also acute, mostly seen in developing regions. But the virology literature highlights a terrifying deviation for pregnant patients. Hep E can trigger fulminant hepatic failure in the third trimester. And treating it is a nightmare because ribavirin, the antiviral drug, is strictly teratogenic. It causes severe birth defects, making it completely dangerous for pregnant patients.
It's an absolute contraindication. The dynamics shift entirely when we look at the bloodborne pathogens, hepatitis B and hepatitis C. These viruses establish decades-long chronic infections, causing persistent low-grade warfare in the liver, triggering the exact scarring and cirrhosis we discussed.
So Hep B for both, it can be acute or chronic and is transmitted by blood and body fluids. Hep B is uniquely complex because it's a DNA virus that physically integrates its genetic material directly into the host hepatocyte's genome. It drives liver cancer even without cirrhosis.
And understanding the trajectory of Hep B requires decoding its incredibly tricky serology puzzle. If we connect this to the bigger picture, we are tracking the viral antigens, the pieces of the virus, and the host's antibodies.
Okay, let's decode the lab markers. The first one is HBsAg, the hepatitis B surface antigen.
Right. If a patient tests positive for HBsAg, it is definitive confirmation that the physical virus is actively present in their blood. They are currently sick or infected.
The ultimate goal is to clear that and develop anti-HBs, the hepatitis B surface antibody. If you have anti-HBs, you are immune, either from clearing the infection or from getting the vaccine.
Exactly. But then there's the HBAg, the E antigen. This is secreted during periods of intense viral replication. If you are HBAg positive, the virus is aggressively multiplying, and you are highly, highly contagious to others.
And what about hepatitis D? I like to compare Hep D to a villain's useless sidekick. It's a defective RNA viroid. It completely lacks the ability to make its own viral envelope. To survive and infect anyone, it must physically hijack the surface antigen of hepatitis B.
It's an obligate satellite virus. It cannot exist without Hep B being present first. Therefore, the Hep B vaccine acts as a 2-for-1 shield. If you block B, D is completely neutralized.
That brings us to Hep C. C for can be silent. It's chronic, transmitted via blood. Hep C is notoriously hypermutable. It constantly mutates its envelope, outrunning the immune system, establishing a silent, smoldering chronicity.
Which is why there's no vaccine. But the direct-acting antivirals, or DAAs, are completely curable now. They physically disrupt the viral assembly inside the cell, curing it in like 99% of cases.
Regardless of what inflames the liver, viruses or alcohol, the dietary defense rules are universal. You need a low-protein diet to stop ammonia production, a low-fat diet because you can't make bile to break it down, absolutely zero alcohol, and absolutely zero Tylenol.
Yes, acetaminophen toxicity is the leading cause of acute liver failure in the developed world.
Because of the NAPQI metabolite, right?
Exactly. Normally, a tiny fraction of Tylenol turns into NAPQI, which is highly toxic. Your liver uses a massive reserve of an antioxidant called glutathione to neutralize it. But in an overdose or in a liver damaged by alcohol, that glutathione is rapidly exhausted.
And once it's gone, the naked NAPQI molecules run rampant, binding to liver cells and causing rapid, widespread necrosis. The liver literally disintegrates.
It's a rapid pathway to fulminant failure. Now, the interconnected nature of this entire system becomes even more apparent when we move down the biliary tree to the anatomical bottleneck, the gallbladder and the pancreas.
Yes, we're moving down the plumbing. The liver makes the bile, but the gallbladder is the storage unit. It holds it until you eat a fatty meal.
Yeah.
But it's highly susceptible to precipitation, forming gallstones. Our sources introduced the risk factors for gallstones using the classic 4Fs mnemonic.
Right. Female, 40, fat, fertile.
The underlying endocrinology here is tied to estrogen, which increases liver cholesterol secretion, explaining the higher prevalence in women, especially around 40 or after multiple pregnancies. If a stone forms and wedges into the exit pipe, the cystic duct, it blocks the outflow. The gallbladder spasms, causing acute cholecystitis.
And this localized inflammation provides the mechanical basis for Murphy's sign. The clinician presses deep under the ribs on the right side and tells the patient to take a deep breath.
And as the lungs fill, the diaphragm pushes the inflamed gallbladder down.
Directly into the examiner's hand. If the patient gasps and suddenly stops breathing because of the agonizing pain, that's a positive Murphy sign.
But the extreme danger happens if that stone drops further down into the main plumbing, the common bile duct. The bile backs up, causing jaundice. And it creates a stagnant pool that gets infected by gut bacteria, causing ascending cholangitis.
Which is a life-threatening emergency. It's heralded by Charcot's triad fever, right upper quadrant pain, and jaundice. If it's not decompressed, it deteriorates into Reynolds pentad, adding severe confusion and hemodynamic shock. The patient will succumb to sepsis rapidly.
So what does this all mean for the pancreas, the innocent bystander in all this? If gallstones are in the gallbladder, How on earth do they destroy the pancreas?
It's all about the anatomy. The common bile duct and the main pancreatic duct merge together at a tiny valve called the ampulla of Vater, just before emptying into the intestines.
They share an exit door.
They do. So the pancreas is a factory synthesizing highly potent digestive enzymes, proteases, lipases, but it makes them in an inactive, safe form called zymogens, like trypsinogen. They are only supposed to activate after they enter the safety of the intestines.
But what if a rogue gallstone drops down and gets stuck perfectly in that shared ampulla of water?
The exit door is locked, but the pancreas is still pumping out fluid. The pressure inside the pancreatic duct skyrockets. This immense pressure causes those safe zymogens to prematurely activate into violent trypsin while still trapped deep inside the pancreatic tissue.
The safety mechanism fails entirely. The active enzymes immediately begin to do what they were designed to do, digest tissue. The pancreas violently autodigests from the inside out. This is acute pancreatitis.
It is ferocious. The top two causes are highlighted by the I get smashed mnemonic, but the main ones are gallstones, more common in older women, and ethanol or alcohol abuse, more common in younger men.
The signs and severity of this are terrifying. The patient has intense epigastric pain radiating straight through to their back. And as the enzymes dissolve the blood vessels, you see hemorrhagic signs. Cullen's sign, which is bruising around the belly button, and Gray-Turner's sign, which is flank bruising.
The diagnostics show massive spikes in amylase and lipase enzymes in the blood.
There is a piece of nursing gold here I want to highlight. Placing a patient in the fetal position or knee to chest physically relieves the pressure. By curling forward, gravity pulls the heavy stomach and bowels away from the swollen retroperitoneal pancreas, reducing the mechanical compression. Furthermore, the consensus for survival has shifted to early enteral feeding, right? Feeding through the gut via a tube instead of an IV.
Absolutely. It connects back to infected sites. If you leave the gut empty, the intestinal wall breaks down, becomes permeable, and gut bacteria flood into the dead necrotic pancreatic tissue. Feeding the gut keeps the barrier intact.
Now, contrast that acute attack with chronic pancreatitis, which is mostly driven by years of alcohol abuse. The pancreas isn't actively autodigesting. It's experiencing an irreversible, permanent burnout. The tissue is replaced by fibrotic scar tissue and calcifications.
The factory permanently shuts down. The result is the loss of endocrine function, causing sudden type 3C diabetes because you destroy the insulin-producing cells, and you lose exocrine function.
Which means no enzymes to break down fats, causing steatorrhea, bulky, incredibly greasy, foul-smelling stools because the undigested fat just passes right through. The lifelong treatment requires taking Creon, synthetic pancreatic enzymes, with literally every single meal just to digest your food.
The systemic fallout is absolute.
It really is. Bringing it all together, knowing how these organs interlock, it fundamentally changes how you view your diet, your alcohol intake, even your over-the-counter pain meds. We've seen how a single stone, a virus, or chronic alcohol use can disrupt the delicate harmony of the liver, gallbladder, and pancreas, causing a systemic cascade from brain swelling to kidney failure. It forces a profound respect for the silent machinery keeping us alive.
And this detailed physiological mapping leaves us with one final, lingering question not covered in the text. We know the liver is the only human organ capable of true, massive regeneration. You can remove 70% of a healthy liver and it will regrow. But in cirrhosis, that superpower is hijacked by the scar tissue.
Right, the regenerating cells just hit a wall of concrete.
Exactly. So if scientists could figure out how to pharmacologically switch off those activated stellate cells, switch off the fibrotic scarring, and turn that regenerative engine back on, could we one day reverse end-stage liver disease from the inside out without ever needing a transplant?
That is an astonishing concept. The cure for end-stage failure might be hard-coded into the organ's own DNA, just waiting for us to unlock it. Thank you for joining us on this deep dive. Take care of your visceral engine room, keep questioning the incredible machinery inside you, and we'll catch you on the next one.